Okay, so hopefully this will work. So welcome to this, and now I've lost my controls on my slides. Parker, I have given you the slide control. Can you advance? Thank you. Our usual map of the addiction TTC. We are funded by SAMHSA, and we have several of our partners from SAMHSA here today. Will, would you introduce yourself and Captain Herod, please?
Sure. Thank you, Meg, and hello, everyone. Thanks for joining us. My name is Will Anginetti, and I am a government project officer on the Tribal Opioid Response Grant with SAMHSA. And with me today, I have our Director of the Office of Tribal Affairs and Policy, Captain Karen Hurd.
Good afternoon, everyone, and thank you for joining us. We're so excited to have Dr. Palmieri with us today to talk about 988 and the crisis continuum of care, and to get your feedback as well. So looking forward to this presentation and conversation.
Housekeeping, we, after today's event, we'll be sending out follow-up emails. We will have the slides and the recording of the session available online within the next couple of days. And we also will provide a link to our GIPRA survey, and we'll also put that in the chat later in the meeting. And we would request that you take a few minutes to fill that out, because that's how we get better. And I am happy to introduce our speaker today. Parker, can you advance the slide, please? Oh, I completely forgot about the land acknowledgement. We typically do a land acknowledgement at the beginning of our meetings as well. We take time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken over and inhabited. Past and present, we want to honor the land itself and the people who have stewarded it throughout the generations. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation of Native American territories, and we respect the many diverse indigenous people connected to this land on which we gather from time immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous peoples and acknowledge that land reparations must be made to allow healing for our indigenous peoples and to Mother Earth herself. And now it is my pleasure to introduce John Palmieri. Dr. Palmieri is an MD and MHA. He is the Senior Medical Advisor and Acting Director of SAMHSA's 988 and Behavioral Health Crisis Team. And
thank you.
Let me get your slides up. I'll be right there.
Yeah, of course. Thank you. Hello, everyone.
Here we are. Okay. Showing up. Are you seeing your slides?
Yeah, there you go.
Okay.
Wonderful. Thank you. So thank you so much for the opportunity to be here and to talk with you all briefly about 988. I'm going to run through some slides that we've put together, and I'm hoping at the end to have an opportunity for informal conversation, questions. I have a couple of questions that I put at the end to hopefully facilitate some of the conversation, but really interested in your thinking, feedback, expertise, wisdom about 988 and how we can move forward together to support the crisis needs, our individuals with mental health and substance use crisis needs. So as introduced, so I'm John Palmieri. I'm the Senior Medical Advisor at SAMHSA and currently serving as the Acting Director for a new 988 and Behavioral Health Crisis Coordinating Office at SAMHSA in the Office of the Assistant Secretary. And it's a pleasure to be here with you today. Next slide, please. Success. Hello, everyone. So yeah, thank you for your patience. We'll go through these slides. Again, this is kind of the agenda, the way that they're organized. Just going to provide a quick overview on what 988 is. Talk a bit more about how that connects to the National Suicide Prevention Lifeline. We'll speak to our vision about how we see 988 as a moment and a catalyst to transform the broader behavioral health crisis continuum. And then, as I said earlier, hopefully allotting a lot of time for observations, questions, comments, and so on. You can go to the next slide, please. So this slide quickly is here to signal that we have a growing team that recently has been designated an office within SAMHSA, where we have a number of individuals who are actively working hard to deliver on this opportunity that 988 presents, recognizing again that we're in a unique moment and a unique opportunity to provide life-saving services for individuals in need. So this is really just kind of a snapshot of all of those who have been involved in the day-to-day work of our team. And it's not even everybody, because there's lots of coordination happening within SAMHSA and outside of SAMHSA as well to support the work, all of which is being led by our Assistant Secretary, who's been a very strong advocate for crisis system transformation. Next slide, please. Here you can see some of those other partners, including our strong partnership with OTAP within SAMHSA and a lot of the regional administrators as well, recognizing that there's certainly a lot of work to be done kind of at the federal level and in our federal headquarters. But at the end of the day, it's important that we are engaged with states, territories, tribal nations to making sure that that implementation actually happens at the local level, because ultimately that's where the individual who's in crisis is going to be served best. Next slide, please. So we just actually, the recent comments from our friends in Alaska, I think spoke to some of this, that we all know that there is a crisis going on in our nation with respect to mental health needs, substance use needs. We know that there are too many individuals who experience suicidal crisis, mental health crisis, and substance use crisis who aren't able to get the support and the care that they need. And here are some alarming statistics that we track through a lot of our survey and surveillance data. Large numbers of Americans with a mental illness or a substance use disorder, frequent suicides. The recent CDC publication for 2000 for the past year showed an increase in suicides. So this remains an alarming statistic that there's a suicide every 11 minutes in the United States. There was a significant increase for about 2 decades through 2018 of 35%. And we know that for young people in particular, suicide is a leading cause of death. It is important to recognize, and I'll talk a little bit more about this, that 988 is building on the structure of the National Suicide Prevention Lifeline, which is currently accessed through this 800 number that you see here. And that Lifeline has been in existence since 2005 and has supported millions of individuals in emotional distress or suicidal crisis. And you can see since 2005, there's been tremendous growth in the Lifeline, initially fielding about 46,000 calls per year. And in 2020, that volume has increased to about 3.6 million contacts, which includes calls and also chats and texts, which have been added to the system in the past several years. Next slide, please. We know that for all the challenges that exist across the United States, we know that there are significant challenges and unique challenges that face tribal nations and tribal citizens. And so many of you, I'm sure, are aware that suicide rates are extremely high among Alaska Native and American Indian populations. And according to some of our surveillance data, the highest among the highest in the country at a rate of about 22.27 per 100,000 individuals. And that these rates are particularly elevated among youth and young adults. We also know that there are lots of factors which complicate and challenge access to care. Tribes themselves are diverse, and so it's not helpful to say all tribes or tribal nations are the same, because there's a lot of diversity among tribes. There's also a lot of diversity in how tribal nations interact with states, what their infrastructure needs and capacities are, and with their political system structure. We also know that the Lifeline system is not always sufficiently trained to work with tribal citizens, and that there isn't always seamless integrated connection between the Lifeline and that local care, culturally competent care, particularly in working with tribal citizens. We know that there's variation in service availability and connectivity, particularly in rural areas. And we also know that there are significant gaps in access to resources in that federal to federal relationship with tribal nations, which is extremely important. And that having a situation where there are not sufficient federal resources creates a situation where there's over-reliance on state solutions, which we know compromises sovereignty. We also know that the COVID-19 pandemic has hit the nation as a whole hard, but has hit particular populations harder, including American Indian, Alaska Native populations. As I said before, funding is a huge challenge. It's spread across many agencies. Often tribal nations are not eligible for some funding streams, and that presents enormous challenges in trying to build up that infrastructure. Next slide, please. So what is 988? So again, as I mentioned, 988 we see as this tremendous opportunity to transform crisis care in the country, creating an easy to remember, easy to access universal entry point in line with other medical services. And our focus for this year for implementation in 2022 is strengthening and expanding the national, state, and territory infrastructure to respond to all behavioral health crisis calls, chats, texts, anywhere in the country. As I mentioned, we are transitioning this 800 number to this easier to remember 3-digit number because we feel that in crisis, people need simplicity and they need low barriers to access care. Remembering an 800 number is not as easy as remembering 988. And we especially want people to have the fewest amount of barriers to access care. It's important to note here that the 800 number is not going away. The 800 number will still be a portal to access the Lifeline. It's just that there will also be this 3-digit code as an easier way to get to the same life-saving support. Next slide, please. You can move on to the next slide. So this slide basically charts a history of the Lifeline for those of you who are less familiar with how the Lifeline has been built. As I mentioned, it initially launched in 2005. So the timeline starting over to the left. And I'm not going to go through every step in the sort of the life of the Lifeline, but it is important to know that initially it was only calls. And now, as I've mentioned, there is the capacity to access the Lifeline through text, and through chat. And then you can see in the past couple of years, there's been some federal action that has paved the way for the 988 code to become that new portal to access the Lifeline. And that code will be fully operational for phone and text by July of 2022. So we are very much on the precipice of that implementation happening in just a couple of months. I also will note here that there has been funding that's been disseminated through the federal government to support implementation of 988 and to support capacity building for 988 as part of this. Next slide, please. This is a snapshot of the geography of the Lifeline network and kind of the structure of the network. There are about 200 centers throughout the country that are part of the Lifeline network. They're generally independently owned and operated centers. So they're not run by federal employees per se, but SAMHSA does have a relationship with the network administrator, which is Vibrant Emotional Health. That relationship exists through a cooperative agreement. And through that, and Vibrant Emotional Health, as the network administrator, oversees the operations of these independent centers to provide training, set standards, support technology, routing infrastructure, and so on. And you can see here that there are different types of centers throughout the country. Some centers, many of them handle only local calls, so calls that are coming into that particular geographic area. And then there are centers that also serve as national backup centers, so that when calls are routed locally and the local center is busy or doesn't have the capacity to answer the call, those get sent to a backup center. And then there are also centers that handle chat and text. Not all centers do at this point, although we're hoping to move in the direction of more chat and text capacity. But currently there are only a subset of centers that have chat and text capacity. And you can kind of see, based upon the sort of key here, how those centers are distributed throughout the country. Next slide, please. This is just more detail about what I mentioned about the routing structure. So this for the individual in crisis, if they call that 800 number, that call is routed to the nearest center to them based upon the area code from which they're calling. We know that there are problems with that because not everybody's calling with a phone with an area code that actually reflects where they are. So those are issues that we're trying to actively work on, but that's kind of how it's routed currently. And if that local center isn't able to answer the call, then that gets routed to a backup center. And when people do call that number, they also have a couple of options. If they're a veteran, there's a press 1 option to be connected to the Veterans Crisis Line. And then there's an option to be connected to the Spanish subnetwork. And then for chats and texts, as I mentioned, those are handled differently currently. So those are basically routed to those national chat and text centers that are a subset of the 200 centers that I mentioned. Next slide, please. So the Lifeline has, as I mentioned, grown a lot since 2005. Lots of increase in volume, increase in technology, increase in capacity through chat and text. Unfortunately, the system has also been quite under-resourced for many years. So the demand far exceeds the capacity. And there are many individuals who are in crisis who need to access the Lifeline who have not been able to, frankly, because the system has been under-resourced. So you can see here that from 2020, there's data here that shows that there are unanswered calls, 15% of calls coming in are unanswered, and then higher percentages of texts and chats that are unanswered. And that's something that we're actively working to address, both with funding, trying to get local states, territories to build out capacity to demonstrate investments at the local level as well in the Lifeline network, and to promote guidance around efficiencies and ways to partner to strengthen the system overall. Next slide, please. I'm not going to spend too much time on these, but one of the things that we are tracking, again, because we do think it's important for calls to be handled to the degree possible at the local level, is how states are faring with respect to in-state response rates. So this is basically this slide is essentially a statement on how states are responding, their capacity to respond to contexts that are routed to the state. You can see that there's a lot of variation there in terms of what the state capacity is to manage the local context at this point. And this is something we're actively engaged with states on. Next slide. One of the things that we are tracking is, given that there are those capacity challenges, we are also expecting a significant increase in volume once 988 is fully operational. So upwards of doubling of the volume from 2022 to 2023 with the rollout of 988, partly because it's easier to remember, partly because there's historic growth, and partly because we want and expect that there are going to be calls that perhaps had gone to 911 or other lines that could be diverted to 988 to provide a more behavioral health oriented response as opposed to a law enforcement response. Next slide, please. So these are just some of the things that we've been actively engaged in to support 988. We have been partnering across the federal government. There are congressional reports where we have flagged what we think are needed resources in terms of investments in 988. There's a report that we submitted to Congress on high-risk populations, American Indian, Alaska Native population being one of those key areas of concern, given the high risk of suicide that I noted at the beginning of the talk. And then have provided some additional support through actual funding, as I mentioned, to build both the national safety net and local capacity, and are continuing to engage in providing coordination, technical assistance, awareness, communications materials, and so on. Next slide, please. This is a snapshot of the many partners who we have been engaging with around 988, largely focused on that readiness piece and how we're advancing readiness across the system for those populations at high risk, addressing inequities where we recognize that there are individuals, populations that don't have the same access to care, and working to, again, try to work with our partners to drive system improvement. Next slide, please. So some of the observations and comments that we have received through listening sessions, through some of that partnership work, is that a recognition that particularly for 988 readiness for tribal nations, there is going to need to be an integrated approach that involves multi-way collaboration between at the federal to federal level, and also with states and territories and local partners and tribal organizations. There have been states that have demonstrated some encouraging partnerships with tribal nations, and then there have been states where that has lagged a bit. And so recognizing that there are opportunities for improvement in this space and that there potentially are states that we can learn best practices from, while at the same time making sure that we're not losing track of that federal responsibility to engage tribal nations directly. And then again, always thinking about ways that we can build guidance, technical assistance, support to promote 988 readiness and culturally appropriate care. Next slide, please. This is a list of some of the listening sessions and engagements that we've had to date. There's ongoing work that we're still planning out, which will both involve further listening opportunities, consultation, and also direct work with tribal nations that we're thinking through in terms of planning processes around crisis services. So those are all things that are underway. We are also expecting that some of this work will result in a specific guidance document that will be of greater relevance for tribal nations. Next slide, please. We also are making sure that we're incorporating tribal citizens in urban environments, Indian Health Board, as well in our work, in our planning and communication strategies. There are activities underway with respect to the network administrator around coordination meetings. We are kicking off some formative research work through our communications team, which will involve direct engagement of American Indian, Alaska Native individuals to better understand their needs, preferences with respect to how 988 is structured and messaging that can inform help-seeking behavior. And then we also are aware of some innovative work that's happening in Washington State regarding a dedicated 988 service, and are very interested in learning from that model. Next slide, please. And I'm wrapping up pretty close to wrapping up. You can go to the next slide. So as I said initially, 988 is critical, and we're looking beyond 988 as well. And this is a journey. This transformation is going to take time, but we're building kind of the groundwork. We're building the foundation. There were crisis care guidelines that came out in 2020. We're building on those through ongoing guidance documents and technical support. And we're fortunate to be able to be in a position where there's more investment and engagement through the White House and through Congress to support increased allocation. I mentioned that the system had been very under-resourced historically. There have been unprecedented investments in the system, and hoping that momentum will continue to move forward, particularly hopefully leveraging some opportunities specifically for tribal nations around funding resources. Next slide, please. This is how all those pieces fit together in that crisis continuum. Some of you have probably seen this before, but the crisis line with the phone there is kind of what 988 represents as a portal into the crisis system. But in a perfect world, the 988 crisis center would be linked to all of these other supports by the mobile crisis, facilities, in-home stabilization services, linkages to wraparound care, culturally competent care, with the idea that we would like to reduce reliance on 911, reduce reliance on law enforcement, decrease hospitalization, decrease arrest. That's really the whole goal for driving system change. Next slide, please. Here are some resources that are on our website that speak to opportunities, both around suicide prevention and more broadly to support crisis system transformation. This includes funding and technical assistance opportunities. Next slide, please. And then keep going. So we really see, in conclusion, this great opportunity with 988, as I said, very focused in on improving answer rates with the funding that we've been providing, and making sure that we're attentive to that broader context, that broader framework around integration of services and scaling those services to make sure that they reach everybody. Next slide, please. Some of the states are showing investment. Many states are showing investment in the 988 system. This is a snapshot of states that have passed legislation that provides cell phone fees that can support 988. So 4 states have done that, and then other states have passed legislation without a fee. Many states have formed commissions. There's varying degrees to which states are pursuing legislative activity, but there is a lot of activity happening at the local level. Next slide. And for the crisis continuum, here are the areas that we're focused in on. Again, the network operations, strengthening that local capacity, building messaging, public awareness, hopefully being able to roll out a full-on campaign appropriately targeted to individuals with inequities in access or high risk. And then we've recently stood up this behavioral health crisis coordinating office to link all of the activities and to drive system improvement. Next slide, please. So this is a concluding slide that basically speaks to why we think this is so important, that people have a right to crisis care and to health care, and we need to think about it that way. We need to make sure that everybody's doing their part. That includes payers as well to support crisis services. And we need to make sure that the system is fully working together in lockstep to support the needs of those individuals. Next slide, please. We have a SAMHSA website, samhsa.gov/988, lots of tools fact sheets, partner toolkits that can be used to disseminate information about 988. So I would encourage you to take a look there for further information. And then our resource mailbox at the bottom there, you can always email us with any questions you have about 988. And I think that's it. Can you go to the next slide? Yeah, so these are some questions that I had or we were thinking about, and you obviously feel free to ask any of your own questions, comments, but curious about general awareness of 988 among tribal citizens. What do you think are some of the barriers and challenges? I know we've mentioned some of them in this talk, but interested in your thoughts about that. What resources would be most helpful to you? Are you aware of partnerships or efforts from states to engage tribal jurisdictions around partnership and planning? And I'll end there and open it up for questions. I think there was some maybe in the chat as well.
There are a few questions in the chat. Thank you, Dr. Palmieri. Brandy noted that on your map that had the states with legislation, that Alaska is the light gray, and we have a question about what the light gray means. Does that mean that those states have not taken any action that you know of? You're muted.
Yeah, sorry. I think on the at the time that this was documented in the slide here, the light gray would indicate that there's no known specific legislative proposal or activity. It doesn't mean that there aren't conversations happening at the state level, because there are in every state. But there wasn't awareness at the time that this was documented of any particular specific bill or legislative activity that was happening in those light gray states.
Ray, you raised your hand.
Ray, you might be muted still.
Okay,
Oh, there we go.
there we go. I'm sorry about that. My name is Ray Dahl. I'm a member of the Navajo Nation, and I'm working with the state of New Mexico Human Services Department, Behavioral Health Division, on Native American outreach and public information. One of the interesting areas of inquiry we have is how strongly the suicide prevention piece is to be woven into the 988 messaging, or whether it's a broader mental health, mental wellness messaging that should be or can be included in the outreach public information process, particularly with tribes that we're working with.
I think I caught part of the question. So, and it's a great one. So we are, as we transition to 988, we sort of have rebranded it to some degree as the 988 Suicide and Crisis Lifeline. And we specifically intentionally did that because we want to make sure that there's still a focus on suicide prevention, because that is critical. And that's part of what the National Suicide Prevention Lifeline has been focused on for all these years. And at the same time, we do want to signal that there's a broader scope here that we think is important. So if individuals are in mental health crisis, or they're in substance use crisis, or they're in some other type of emotional distress, we want to make sure that they are aware that they can access this lifeline as well. So we are focused in, and some of our messaging that's in the website that I referenced, we have some frequently asked questions about the scope of the lifeline. And so there's definitely some information there that I think could be helpful to address some of that. But the short answer is suicide prevention, huge priority. And at the same time, we see that there's need for broader inclusion of crisis situations that aren't always strictly suicidal in nature.
That helps quite a bit, because I think
Ray, I think we lost you.
I think we lost him.
We
Yeah.
lost your audio.
Oh, well, thank you for your comment. I'm driving right now, so I'm sorry about my connection. Okay.
No problem.
We have two other participants who have raised their hand. Kathy, you had a question?
I have several questions. The one that came first was, there's a relationship between crisis intervention and services. And if you're looking at the state level, do you see your mission or one of your goals is trying to help states to blend those pieces together to increase the likelihood that, especially if somebody is chronically suicidal or has chronic substance abuse or other mental health issues, because there is a treatment gap in our care across the country as well. So that's one question. As an advocate for Native American people, my question also is, in your, would you consider, or have you already done, and I haven't, apologize, I haven't read your on the website, a frequently asked question for Native American peoples solely as a way to help us understand how different tribal communities issues regionally could be addressed, and what kind of support the SAMHSA can give to regional issues that are culturally informed. So because as you mentioned earlier, there's a lot of diversity in Native American country. So, and there's a diversity in resources as well. So a suggestion might be to maybe just have a separate frequently asked question and resource sheet for Native American peoples that includes the voice of the Native American community it's trying to serve, which would, I think, strengthen the diversity and support the diversity issue across Indian country. I think I'll stop there because that's a mouthful.
No, I appreciate the comments. The FAQs, I think there is an FAQ that sort of asks, that's a question about tribal citizens and tribal nations. But I think to your point, I think that there's something that could be more like I think it's one of the things that we're thinking about with respect to this sort of fact sheet or guidance document or tool, a companion tool that could be used that reflects the voice of tribal citizens in terms of supporting implementation. So it's one of the reasons that we are trying to think more broadly about listening sessions, about crisis action planning processes, where we're engaging a range of tribal nations around crisis services planning, and then trying to lift some of those either common considerations or common themes or strategies or solutions that have been generated to provide guidance specifically for tribal citizens. And so I think there's definitely things, and our FAQ document on the website is supposed to be evolving. And so if you have suggestions on things that you think would be helpful, very happy to take those. And at the same time, I think that there's probably another level of detail that probably would be helpful as well.
Dr. Palmieri, there's several questions in the chat. I didn't know if I could just read some of these and maybe you could respond accordingly. I know Katie B says, can you expand more on the states who do have the funding through the fee?
So yeah, there are 4 states that have passed legislation with fees. Virginia, I'm going to get them wrong. Virginia, Nevada, Washington. Why am I forgetting the 4th one? There's a 4th one. If you went to the map, I could tell you it's Virginia, Nevada, Washington, and then Colorado. Sorry, it's Colorado. So those are the 4 that have passed fees. And those states are all in various degrees of kind of planning around sort of that revenue, and then using that revenue to build out their crisis systems. And they're all kind of looking a little bit different in terms of how they're doing that. But those are the 4 states that have passed the fee.
Another question that came through was from Susan A. She says, can you elaborate on how the response teams might do their work in the field?
Yeah, that's a really critical piece in the way that the model is supposed to work for individuals who call 988. I guess, first of all, the vast majority of people who call 988 don't require another immediate intervention. So the 988 contact in and of itself is an intervention to destabilize a situation in crisis. So there have been lots of studies looking at this, and most people who call 988 don't immediately need something else. But for those who do, what has historically been kind of the default response if there's a concern that can't be addressed over the phone is to call 911. That then entails law enforcement or emergency medical providers or whoever that's connected to the 911 response. And so optimally, we really would like to see those 988 calls, when there is a need for an immediate response, to be linked to a mobile crisis team where there are typically a pair of workers who are truly mobile and who go to that individual in crisis to support them, to provide crisis intervention services, and again, try to stabilize that crisis without having to have the individual put in handcuffs, transported to the hospital, and so on. So that is the intent behind the model in terms of how optimally it will work. The degree to which localities have mobile crisis is extremely variable at this point, and this is a piece of engagement that we're working with states around building mobile crisis capacity.
Thank you. It looks like I wanted to note too, I think it's Colby C. Has put a link in here related to some 988 information specific to Native communities. So there's a link in the chat if anyone's interested in exploring that. Mary N. Says, is Vibrant Emotional Health also responsible for hiring professionals to do the work with the call centers, or does this vary state to state?
Yeah, so it's a good question. So the Vibrant contracts out with the centers that are scattered around the country, kind of on that map that we reviewed. So those centers do the hiring. Vibrant as an administrator and overseer of the network. I mean, they obviously have staffing needs as well, but they're not the ones answering the calls. They have contracts with centers that answer those calls, and so the hiring happens at the center level. And we are very close to trying to make it easier for individuals who might be interested in those sorts of opportunities to have awareness of those employment opportunities.
Thank you. I had a question too. This, aside from the obvious, but how will we know that this is working? I'm thinking more like the ripple effect, or how this might impact other systems, systems of care. How will we know the 988 rollout is working?
Yeah, so it's a great question. One of the things that we're most immediately focused in on are those answer rates, and making sure that we're seeing kind of a trajectory of improvement in those answer rates. Yes. Given that we're starting at a place where there's clearly some challenges and opportunities for improvement, so we want to make sure the calls that there are increases, that we're seeing gradual increases in those answer rates, in the timeliness of the response, those kind of key performance metrics that are associated with the actual crisis centers themselves. Ultimately, the things that we would like to be looking at are people being linked to care following their crisis encounter? Are there fewer 911 dispatches? Are there fewer transports to emergency departments? Are there fewer law enforcement contacts with individuals in crisis? Those are all measures that we're actively going to be looking at.
Thank you very much. I know we're approaching the top of the hour. I know Meg asked me to conclude our discussion today. She's having I think some home repairs going on at her house. So she didn't want to have the audio issues. But I wanted to, we have a few minutes left before we wrap up. I know there's a short survey link that's been posted in the chat. Are there others who would like to unmute and perhaps ask a question directly to Dr. Palmieri or to the group here that's on today?
And I would just say, for those who want to continue the conversation, please email us, email the 988 email address that was noted on the slide there. Happy to engage folks in more conversation.
Dr. Palmieri, I noticed in one of the slides it mentions a notice of funding opportunity for 988. And so what will that be for? So there's going to be a grant awarded to?
Yeah, so that 105 million that went out, it was awarded recently, went to states and territories to support local investment, with a requirement that there is engagement of tribal nations as part of that grant award. And then we are also looking at some other funding. There's a mobile crisis partnership grant that it's not out yet. It's a pilot program looking at some of those first responder mobile crisis partnerships that will be coming out. And again, we're looking to have very specific language around eligibility for tribal nations, tribal organizations as well.
Great, thank you. And I know the Native Center and Meg and Steve will send an email out with the slides to everyone. And we can include the resource that Colby linked to as well.
I also just posted the email that Dr. Palmieri referenced in the chat for people to continue the conversation.
I just want to thank you guys for coming on. It's been interesting to learn more. And I have another call at 2, Meg, so I'm going to step off. Great to see everyone, and I'm sure our paths will cross again. So thank you for the invite.
Thank you, Steve.
Yeah, I just want to also just echo the thanks. Really appreciate the participation and the engagement and the questions. I hope that we can continue the conversation. So thank you.
Thank you, Doctor.
Thank you, everyone, and have a good rest of your day.